There we go. I do have disclosures. They'll show up in a minute. So one of the things that I think was not clearly distinguished in the last presentation is the differences in what we know and where we're headed in primary and secondary MR. And I'm going to structure my talk about where we are investigating therapies in these different buckets for primary and secondary MR. These are the devices that are in commercial use in Europe. MitraClip, of course, is the only one approved in the U.S. Two of the other three, the Cardioband and the Cardiac Dimensions coronary sinus annuloplasty device, are headed for trials. Again, I'm going to frame this in terms of what we're studying because I think that highlights where our immediate gaps in understanding and ability to utilize therapy reside. And I want to use this schema. We have degenerative and functional MR and low and high surgical risk patients. Low surgical risk DMR patients we accept as standard of care is clearly surgery. This is well established. Trying to study this in a randomized trial against medical therapy would be like studying parachutes. Low surgical risk functional MR is where we have the least understanding of where benefits for therapy might lie. High surgical risk degenerative MR, non-surgical, MitraClip is our currently only alternative in the U.S. And in functional MR in high surgical risk patients, we have a large amount of international practice experience with the CE mark approved devices. One place where there is an interesting randomized trial going on, and that is in that upper right quadrant of patients, actually spans both low and high risk functional MR, is a randomized comparison of surgery and MitraClip for FMR. And this is enrolling slowly. It's a MATTERHORN trial ongoing in Europe, relatively small enrollment, but I think this will be really interesting because it will address some of these lower risk FMR patients, at least comparative with annuloplasty surgery. The big bucket, the place where we have the most uncertainty, the greatest clinical need, and the most activity is in functional MR in high-risk patients. And most of us are familiar with the COAP trial. There are several other trials ongoing in this space, and I want to talk about them and what our expectations might be for these trials. COAPT is the largest, 615 patients. June 23rd, enrollment completed with 614 randomized, and these are patients with depressed EF, EF less than 50%, and symptomatic heart failure defined by heart failure hospitalizations or elevated BNPs. So we're in the waiting period for follow-up and outcomes, and I want to ask the question, what can we expect from this trial? There are several meta-analyses like this one that have been published that have tried to propensity match patients who would be the typical, what we hope would be the COAP patients. So this is a matched registry analysis, 60 high-risk MitraClip patients, severe MR. This is from a single center. Mean EF of 34%, about half of with ischemic cardiomyopathy. And I think the data are very interesting. First of all, their big prediction is that both overall survival and survival free from heart failure hospitalizations are superior with MitraClip compared to medical therapy. But I just want to look at the 12-month number here because that's the COAPT endpoint. And the overall survival in the MitraClip group is over 90%. And the rehospitalization rate in the MitraClip group, and actually you see it's pretty close at 1 year in both groups, is a little over 20%. These are data from the TVT Registry, most recent TVT Registry publication. This gives us a snapshot of who's being treated in the United States, and you can see that the mortality, in contrast to that MitraClip matched analysis, the mortality is more than twice as high, and the rehospitalization rate is similar in the mid-20s. Now, the COAPT endpoint is rehospitalization, not mortality, and the trial enrollment was bumped up from 400 to 600 plus because the early mortality was high enough to diminish the chance for heart failure rehospitalizations. And I think what we see in both of these real-world looks at similar populations is that this is a problem, that the mortality rate in this group can be very high, and that it might, at 1 year, mask rehospitalizations. So I don't think the trial outcome is a slam dunk or a sure thing by any means, and that we will really need to wait and see. There's another variable that I'm not showing slides on because this is such a limited talk, but I'm going to guess based on the roll-in data for COAPT that between a quarter and a third of the enrollment will be cardiac resynchronization therapy failures. And this is a group, they're really very limited data on how they do with MitraClip, and it remains to be seen whether they will respond or not to MitraClip therapy. So we have two other trials, MITRA France, which actually completed enrollment 6 months ahead of COAPT, Reshape Heart Failure 2, which is ongoing. There are a variety of differences among these trials, the biggest one being that MITRA France and Reshape have death and rehospitalization for heart failure in the endpoint. So we will get, and the trial follow-up differs, but the endpoint's 12 months for all of them. So we'll get several looks at this issue, and we have to hope that these trials are generally positive, because this is the unmet need we have, the MR with heart failure. Cardiac Dimensions Carillon I want to talk about for a moment, because they are also on the cusp of mounting a IDE pivotal trial in the United States. To date, there have been probably pushing 800 patients treated worldwide, over 100 treated in prospective trials, and looking at the trial results objectively, they're not that much different than either MitraClip or Cardioband. So the Cardiac Dimensions is launching a 400-patient pivotal trial, 2-to-1 randomization, a hierarchical endpoint using the Schoenfeld type Win analysis that includes death, heart failure, and 6-minute walk test. And this is unique because it gives several measures, including 6-minute walk as a quality of life and functional measure as ways to win. Cardioband is also organizing a U.S. IDE trial. This is lauded as being the closest thing to a surgical annuloplasty. And I want to just delve into that consideration a little bit. Small number of patients at 2 years, but very stable MR outcomes with Cardioband. Now, why should, if we say that Cardioband is similar to surgery, why should we expect better or different results than surgery? We have annuloplasty in the CTS-NET trial, prospective examination of the outcome of annuloplasty, pushing 2/3 major recurrence at 2 years. And I want to suggest that the difference between catheter therapy and surgery is that catheter therapy we iterate during the procedure in the beating heart so that we can target the therapy to the result in real time. And of course that it's not surgery, so the penalty of cardiopulmonary bypass isn't built into the outcome. But again, that remains to be seen, and we will have a prospective comparison of the Cardioband with medical therapy. New kid on the block, the Edwards PASCAL system, creates a double orifice, uses a spacer in the middle, and the device is characterized as a spacer with clasps. Here's a fairly typical case from the compassionate use European experience. Large flail gap in this case, and you can see the result, and the spacer occupies the gap, and that's a fundamental difference compared to MitraClip. So a early feasibility study is developing in the U.S. And then, of course, the last part of the landscape of mitral therapy is now the development of replacement devices, and none of them are in IDE trials yet. They're still all in the feasibility stages. 12 or Medtronic Intrepid organizing a IDE study. One novel therapy, again, a very short talk, very hard to talk about the whole landscape, but we've started to recognize that anterior leaflet displacement with LVOT obstruction is a rate-limiting step for a lot of the mitral device replacement development. This is one novel therapy to use radiofrequency energy to lacerate the anterior leaflet to facilitate TMVR and minimize the problem of LVOT obstruction. There's a bioptome device in development that can be used to remove septum. That's another approach to this. So as we look at this going forward, we have these repair technologies that are very low risk, but generally leave some residual MR. We have replacement devices that are higher risk but better for resolving MR. And until we see these migrate in the right direction, it's going to be hard to say what's going to be predominant. Thank you.